Hello, everyone. Carla, should I get started? Well, I'm going to start. So thank you so much for joining us today. I'm Dr. Carol Warshaw. I'm the director of the National Center on Domestic Violence, Trauma, and Mental Health, and we're delighted to present today's webinar on overdose prevention and reversal and anti-domestic violence advocacy as part of the National Center on Domestic Violence, Trauma, and Mental Health series on trauma, opioids, and DV. As many of you are aware, accidental drug overdose is the leading cause of death for people under age 50 in the United States, claiming over 72,000 lives in 2017. And people who experience abuse from their intimate partners, as again, many of you know, are at increased risk for substance use concerns and often have a much harder time getting help because of the ways that their partners control their access to treatment and sabotage their recovery efforts, a form of abuse known as substance use coercion. This webinar will support advocates to empower survivors with potentially life-saving information on how to prevent and reverse overdose. This includes information on the opioid overdose antidote naloxone, or sometimes known as Narcan, risk factors for overdose, advocacy strategies to reduce the risk of overdose, evidence-based approaches, and cutting-edge interventions in the fight against fatal overdose. The objectives are to identify factors that increase the risk of an accidental fatal overdose, identify signs of opioid overdose and steps in preventing fatal overdose, and being able to describe innovative collaborations and evidence-based strategies in preventing overdose. Today's presenters are Gabriela Zapata Alma, who is the Director of Policy and Practice for Domestic Violence and Substance Use here at NCDV TMH. Gabriela is the LCSW CADC, is the Director of Policy, as I mentioned, Practice here, as well as for deviant substance use, as well as an adjunct faculty member at the University of Chicago. Gabriela brings over a decade of experience working with survivors of domestic violence and other trauma, providing direct services, training, advocacy, and consultation, and leading programs using a trauma-informed approach, motivational interviewing, harm reduction, gender-responsive care, housing first, and third-wave behavioral interventions. Gabriela has been recognized with numerous awards, including Health and Medicine Policy Research Group's 2018 Health Award and the Illinois Association of Addiction Professionals chapter of NADAAC's 2017 Rising Star Award. Gabriela has provided training and technical assistance related to serving marginalized communities impacted by trauma and other social determinants of health, locally, nationally, and internationally, as well as for numerous federal agencies. Our second presenter is Ileana Espinosa-Ravi, who is the Community Overdose Prevention Program Manager and Outreach Specialist for the Chicago Recovery Alliance, an organization dedicated to the philosophy of harm reduction and serving people actively using a variety of substances. Prior to joining the CRA team, Ileana worked as a mental health worker in the Housing First program, as well as in community-based behavioral health centers to support people who were struggling with mental health and substance use-related challenges. Ileana has been involved in social justice work since 2009 and has worked in the field of behavioral health since 2014. Ileana strives to approach her work from an intersectional framework that addresses health justice from a variety of lenses, including those specific to race, gender, ability, and socioeconomic status. Before we get started, I'd like to go over some technical details of the WebEx software that we'll be using for today's webinar. Many of these details are explained on the Using this Webinar System tab in the center of your screen. You can switch to the screen from the slides by clicking the down arrow next to Using this Webinar. Please be aware that your screen might look a little different depending on whether you're using a Mac or a PC. On the right-hand side of the screen, there are multiple boxes. The third from the bottom is the chat feature. You may have to click on the chat cloud icon at the bottom center of your screen to open your chat box. This feature will allow you to provide feedback and share resources with your fellow colleagues, as well as get in contact with the trainers or myself if you have questions regarding the training content. You may contact Carla Alegria, also with the center, if you have questions troubleshooting the WebEx software. To do this, click the down-facing arrow and select the person you would like to contact. You will see a lot of options. You want to take a look right now. But for this session, you'll want to select all participants if you'd like to respond to a question from the trainer or to contact center staff at any time during the session. You should click on Carla Alegria to privately contact her if you're in need of troubleshooting the WebEx software. So let's test this chat feature. Will everyone please go to the chat box, click on all participants, and type in where you're calling from, and then press enter. Perfect. Thank you all very much. While people can get a lot out of the chat feature, there are times when it moves really quickly and it can feel distracting. If this is true for you, please feel free to minimize the chat box by clicking the arrow next to where it says chat. You can always open it again with the same arrow if you choose. Also, we will be providing live captioning during the webinar. Below the chat box, there's a media viewer box. This will contain the captions. If you do not want to see the captions, click on the down-facing arrow next to the word Media Viewer, the same way you might if you want to hide the chat box. Time permitting, I will be moderating the Q&A towards the end via the chat box. And at the very end of the webinar, you'll be taken to a brief survey. Please take a moment to let us know what was useful and what could have been better. If you get disconnected at any point, return to the email you received with the original webinar link and re-enter the webinar. Sometimes the sound cuts out due to internet connection, so please feel free to call back in if that's a problem for you. If you are experiencing technical difficulties and are unable to contact Carla, you may call WebEx tech support to resolve any issues. That phone number, which I'll post in the chat box, is 1-866-229-3239. And again, thank you very much for joining us today. I will now turn it over to Gabriela.
Thank you so much, Carol. Thank you so much for all those instructions and that introduction. So jumping in, a little information about our center. We're a self-funded special issue resource center dedicated to addressing the intersection of domestic violence, trauma, substance use, and mental health. And here's some additional information, including that the points of view in this document are those of the presenters and do not necessarily reflect the official positions or policies of the U.S. Department of Health and Human Services. And our objectives for today, which Carol already shared with everyone, here they are again. And so starting out with, what's the connection? Why even talk about substance use when we're talking about domestic violence and experiences of trauma? Well, what we know from our day-to-day practice, as well as from what data can show us, is that domestic violence, trauma, mental health, and substance use are highly interconnected. So we see that domestic violence and lifetime trauma have significant mental health and substance use-related effects, including high rates of depression, post-traumatic stress disorder, suicidality, chronic pain, substance use, including opioids, and that adverse childhood experiences can also lead to increased risk of intravenous drug use and overdose. We also know that there are high rates of domestic violence and other lifetime trauma among people accessing substance use treatment, so much so that there was a study that found that 90% of women attending a methadone clinic had experienced domestic violence in the past year. We also see high rates of substance use among people accessing domestic violence services, and self-medication or trying to use drugs in order to feel better is common. So on top of these interconnections, we also see substance use coercion. And so substance use coercion comes up a lot of different ways for individuals, where someone who uses power or attempts to use power, control, and abuse against their intimate partner really targets their substance use and potentially as well their mental health in the pattern of abuse. And so we found that there are really high rates of people being introduced to substances by an abusive partner, people being forced to use or use in ways that are unsafe or that they don't want to use in those ways. Exposing people to situations that will lead to them using in ways that they don't want to use, or for those that are attempting recovery, really exposing them to situations that then result in relapse. And there's a whole lot of other ways that this comes up as well. And here's some data from our research project with the National Domestic Violence Hotline. And so really seeing very, very startling high rates of substance use coercion amongst all callers. So these were all callers, not callers that were particularly screened because they had used substances or not. These were just all callers. And we see that on top of the pressure to use in ways that are unsafe, really attempting to control someone through substances, that survivors are then even further isolated because of the abusive partner or ex-partner threatening to report their substance use in order to separate individuals from protection, from support, from social support, from things that they need and want. And so why is this form of abuse so pervasive? One of the top reasons is because of the very stigma associated with mental health and substance use conditions, and that because of the stigma that exists, then it becomes so much easier to attempt to exert power and control over somebody by targeting their substance use. And so in this way, one of the most important things that we can do in counteracting the attempts of substance use coercion is to really work from an anti-stigma framework. And so looking at accidental fatal overdose. So overdose is the leading cause of accidental death in the U.S., and it is the leading cause of death for people under age 50. So more people have died from accidental overdose than peak car crash deaths in 1972, peak HIV-related deaths in 1995, peak gun violence deaths in 1993. So we have here the numbers from 2016 and 2017 showing really drastic increases in people we've lost to overdose. Now, the most recent preliminary numbers from the CDC for 2018 show a slight dip in overdose fatalities. So while it's still too early to see whether there will be an actual decrease and a significant and sustainable decrease, we are hopeful that many of the strategies that we're going to talk about today are having a significant effect on preventing fatal overdoses from escalating. Overdose prevention, and then this says we can prevent overdose by making naloxone free, accessible, and available to all, especially stigmatized communities. So when it comes to evidence-supported opioid overdose prevention, there are three things that we know for sure have a significant impact in preventing fatal overdose. And we'll talk a little bit about this first one, a lot about the second one, and then overdose prevention centers, we won't talk too much about. They exist in many countries across Europe, as well as Canada and Australia and other countries, but none exist in the United States at this time. We do have a slide at the end of this presentation with some resources on what overdose prevention centers are in case people want to learn more about those. So this following section will focus largely on overdose prevention as it relates to opioids, such as heroin and different kind of pain reliever pills, such as fentanyl and Norcos and different kinds of pills like that, Oxycontin, and But something to note is that fentanyl, which is an opioid, has been found in some street-based stimulants, including cocaine and methamphetamine, contributing to escalating fatalities. So we also will talk a little bit about overdose prevention, or maybe opioids in stimulants as well as just stimulants. That said, this information is important and relevant for everyone who may use substances and anyone who knows someone who may use substances. Medication-assisted treatment. So medication-assisted treatment, what we're typically talking about here are medications that are used in the treatment for opioid use disorders. So we have methadone, which folks are probably familiar with methadone clinics. It's a highly regulated medication, and it's one of the most studied medications in all of history, and it's been found to be safer than aspirin. So it's something that there's a lot of times there's a lot of stigma around methadone, and what we've seen time and time again through research is that it really is effective in helping people engage and sustain recovery from opioid use, and it's also very effective in reducing the risk of incarceration, reducing the risk of different contracting different diseases such as HIV and hepatitis C, and that people are able to really engage meaningfully in their recovery and return to work and school and other kinds of meaningful life activities with the help of this medication. We also know that there is a growing body of evidence showing that buprenorphine is also effective in this manner. And buprenorphine, when it's combined with naloxone, is known as the brand name Suboxone. So some folks may be aware or have heard of Suboxone. Now, some safety considerations when it comes to medication-assisted treatment for survivors is that, particularly with methadone, there is one location that a person needs to go to, typically at an established time on an established routine. So usually it's every day for a period of time, and then as people meet different goals and continue to show progress in the program, then they can start taking some methadone home and might go from going every day to several times a week to once a week, and then after a very long time, the program may be able to go longer than 1 week. Now, that can present some safety risks for people who may have a partner or an ex-partner who follows them or stalks them. And so something to keep in mind is helping survivors build that into their safety planning, as well as helping to negotiate with providers and broker relationships with providers to see what can be done and how they can be flexible in order to meet the safety needs of survivors. Because of the very rigid schedule often involved in methadone treatment, many survivors may select buprenorphine or Suboxone, which is written as a prescription filled at a local pharmacy and then taken as really any other medication. And so that may be a more optimal choice that some survivors make as they consider their safety needs. There's also naltrexone, which is available in a monthly injection. While there is some evidence supporting the use of naltrexone in medication-assisted treatment, it is not nearly as robust as the medication for buprenorphine or for methadone. And so looking at overdose education and naloxone distribution in community settings, so meaning non-medical settings, which means all of our settings. And this says, overdose touched me when a participant trusted me to save his friend's life. So we want to take a moment and hear from you. We want to hear, does your program have naloxone available? Some folks may be familiar with naloxone by the brand name Narcan. And if you don't have naloxone available at your program, are you considering having it on hand in case of there being an overdose? And we'll give you a little time to enter your responses in the chat box. So we see we're working on establishing a program due to situations we've already experienced in our shelter. Staff here have been through training and have naloxone in hand. We're training using Narcan yearly and have it on us at all times. That's great. We hope to consider it. Don't have it, we are considering it. Not on site, but looking to keep it on hand. Great, thank you, everyone. It looks like everyone either has it on hand, has some training available, or don't have it but are considering it. That's great. Well, we really hope that we're so glad you're here today participating in this webinar, and we hope that through this conversation, some of those questions can be answered and that we can support you. So now I'm actually going to turn it over to my co-presenter, Ileana, to tell us about Chicago Recovery Alliance and how they have been using community-based overdose education and naloxone distribution for decades.
Great. Thanks, Gabriella. Hi, everyone. Thanks for being here with us today on the webinar. So I work for the Chicago Recovery Alliance, and for folks who might not be as familiar with CRA, we are one of the oldest and largest harm reduction programs in the country. We focus on reducing drug-related harms among people who are actively using drugs, and really started as a syringe access program for people who injected drugs, but have since expanded to sort of providing a wider array of services for folks who use drugs through other routes of administration as well. And our mission is to support any positive change as a person defines it for themselves. We try to infuse that mission in the way that we deliver all of our services. So we provide a variety of services, and not all of them are specifically about overdose prevention. But I will say we were the first overdose prevention and naloxone distribution program in the world focused on getting naloxone, the opioid overdose antidote that we'll be talking much about today, into the hands of people directly impacted by overdose. So that was specifically people who were using drugs and then loved ones of people who were using drugs. And our services include distributing safer use equipment, including injection equipment, smoking and snorting supplies, safer sex supplies, harm reduction counseling. We were the first overdose education and naloxone distribution in the world, as I mentioned, so that's a lot of what we do is a lot of training and technical assistance, and then actually distributing the medication at our outreach sites. We also provide treatment referrals and do some drug checking, which I'll talk a little bit about later. And so because all of our services are about reducing drug-related harm, inherently all of our services are connected to overdose prevention. So one example of that is we do HIV and hepatitis C screening and then linkage to care for folks who are positive. So folks with HIV, we know that they're at elevated risk of overdosing when using drugs. So helping folks stay up to date with their status and linked to treatment when positive is a great way of reducing one's overdose risk. So that's just one example of how our other services are also connected to overdose prevention. We can move to the next slide, Gabriella. So this is for any of you out there who love data and research. So the purpose is really just to illustrate that overdose education and naloxone distribution programs are evidence-based, and that we know from many years of research that essentially they cover these main points. So for any of you out there thinking about starting your own overdose prevention program, this can be a really great resource for you to take to your leadership. So we know that these programs are totally feasible to implement in a variety of settings, including treatment programs. We know that they increase knowledge and skills. We know that there's no actual increase in drug use when initiating these programs, but we actually see a positive correlation with increases in drug treatment initiation. We know that they actually reduce overdoses in communities. So they actually have what in public health we call a dose-response relationship, where the more you saturate a community with naloxone, the more you see reductions in actual overdose fatalities. We know it's incredibly cost-effective, right? Rather than having to rely entirely on the emergency department for every single overdose reversal. We know that reversing them in communities and then connecting people to care afterwards is incredibly cost effective, and it's also increases the chances of survival for folks when oftentimes, ambulance services can't get there in time. And we know that they're incredibly effective when they focus on people who are using drugs, right? People who are most likely to be there when an overdose occurs and are most likely to be the folks to use naloxone. When programs focus on getting it first and foremost into the hands of people directly impacted, they have the greatest success. Next slide. All right, so one of CRA's original founders was Dan Bigg. Maybe some of you had the privilege of getting to know him. Many of us are remembering him this week as he passed away a year ago this Wednesday. But Dan was important to remember, not just because he was one of the CRA founders, but also because he was one of the original advocates that helped bring harm reduction to the United States, actually. And it was really his vision that put naloxone in the hands of lay people beginning in 1996 that has since led to thousands of overdose reversals and lives saved. So as you can see, the medication was first approved by the FDA in 71, and then in 96 was when we started the first community-based distribution program. And then it wasn't until 2010 that we saw the first sort of law enforcement unit in Massachusetts start carrying naloxone. And then to the next slide, it wasn't really until 2014 when we started to see a really big uptick in illicitly manufactured fentanyl and, huge increases in overdose deaths that a lot more people started to view naloxone positively, because up to that point it had really only been syringe access programs who had been distributing this medication. And so around 2014 is when we started to see a lot more sort of public support. And now it's still a little controversial in some settings, but a lot of people are recognizing both the importance and the need for naloxone to be widely distributed in various community settings. All right, next slide.
And Eliana, I wanted to pipe in real quickly. It really, I found it so inspiring when I found out that CRA had been doing this work for decades and had been doing this work with a lot of positive outcomes, because when we first started doing naloxone distribution in my past organization, one of the common concerns was, we're not medical staff, we're not trained as nurses or physicians, and naloxone is a medication. How can we, what's our role in this? And then having found out that CRA had been putting this in the hands of community for decades, and, without any kind of medical training, and all the lives saved was just so inspiring.
Absolutely. Thanks for saying that, Gabriella. I forget sometimes what people do and don't know about CRA, but none of us are actually trained medical providers. All of us are lay people, and many of our staff have lived experience. We do have a medical director, which has allowed us to basically take what's a prescription medication and do third-party prescribing, and we'll talk a little bit, I think later on, Gabriella will talk a little bit about laws in different states. But essentially, yeah, just know that your program doesn't need to have nurses or doctors necessarily on hand. We're all sort of regular people doing this work and have been doing this work for a long time. So it's been very, what's the word? It's not been super professionalized, I guess, and doesn't have to be for sure. So. All right. So let's get into a little bit about how to prevent and respond to an opioid overdose. Risk factors, there are several, but really some things to keep in mind when thinking about starting to develop these programs is, who are the folks that are the most at risk of overdose. And we know for people experiencing housing instability and incarceration that this is the #1 cause of death for those two groups. And then people going in and out of treatment, particularly folks going in and out of detox without sort of a clear aftercare plan or linkage to sort of longer term treatment, like medication-assisted therapy, such as methadone and buprenorphine that Gabriella alluded to earlier, particularly folks going in and out of detox are at increased risk of death as well. And this has largely everything to do with tolerance. So when folks aren't using the same amount that they normally use, so even just a couple of days of not using the regular amount, people experience drastic changes in their tolerance, which puts them at greater risk of overdose when they then go back to using a higher amount. So this is true when people are coming out of jail or prison and go back to using. And then for people living with HIV/AIDS as well, they're at an increased risk of overdose. So similarly too with people experiencing homelessness, you know, having very high levels of stress, having perhaps other chronic health conditions, not having regular meals or adequate sleep or a safe place to live or a safe place to use. All of these contribute to a person's overdose risk.
Thanks, Ileana. And some additional risk factors are using alone, because nobody is there to notice that the person may be overdosing and then responding to the overdose. Because we're unable to reverse our own overdose. It's really somebody else who's going to notice that we're overdosing and then respond to our overdose. A history of overdoses. I often think about this as, you know, once our overdose threshold has been reached, then it becomes a lot easier to overdose in the future. Ileana mentioned an erratic pattern of use, so using you know, different times of the day or using different kinds of substances from different sources, anything that would lead to an erratic pattern. Mixing any substances, but especially with other central nervous system depressants such as alcohol, anti-anxiety medications like benzodiazepines, best known as like Xanax, any physical health conditions, not testing the dose. And testing the dose means using a very small amount of the substance to see where our tolerance is and what the kind of effect it is on us before using what might be considered a more kind of standard dose. Any pattern of kind of impulsivity can lead to that erratic pattern of use. The quality of the substances, so especially when we're getting substances from different sources or substances that we just frankly don't know what is actually in the substances and how, what else might be in it or how potent the substance is. Any history of suicidality, self-injury, depression, or depressed mood can also lead to a more erratic or impulsive pattern of use. A recent period of abstinence, and we see that with folks, you know, leaving incarceration, leaving hospitalization, really leaving any environment that they were cut off from substances or not able to use, or a planned period of abstinence, for example. Just knowing that tolerance shifts really rapidly with opioids, unlike what we're used to with some other substances. The route of administration, while it's possible to overdose by any route of administration, if the way that the substance is introduced into our body is much more rapidly absorbed, then our intoxication level increases much more rapidly, and that can increase the risk of overdose. So injection drug use is the most rapid, followed by smoking, followed by snorting, and then eating the substance. So having someone use a less direct route, or I shouldn't say having someone use, but if someone chooses to use it by a less direct route of administration, that can help reduce their risk. Not having an overdose prevention plan, even just having a conversation with someone and talking through what are some of the ways that they increase their safety and prevent overdose, and what are some things that, who are some people who are around when they're using, who might notice and who might help them out by seeking medical attention and or giving them naloxone, that in and of itself helps prevent overdose. And so not having an overdose prevention plan increases risk. And then finally, when somebody seeks profound intoxication, so somebody who just uses a little bit of opioids just to not feel withdrawal, is that not as high a risk. There's always risk but not as high a risk as someone who is seeking a much more altered state. And so we want to take a moment and hear from y'all. So in kind of practicing hearing and looking for some of these overdose, potential overdose risk factors, looking at Kelly and her situation, I'd love to hear from folks in the chat box highlighting what are some potential risk factors for overdose that we see that Kelly may be experiencing. And I'll read it out loud as well. Kelly's a 24-year-old woman who recently entered the shelter with her 2-year-old daughter. She uses opioid pills and marijuana daily and is prescribed benzodiazepines for anxiety, which she takes 1 to 2 times a week. She typically begins using marijuana and opioids in the morning and used again during her daughter's nap time and then again at night after her daughter is asleep. She has a history of unplanned pregnancies, suicide attempts, self-injury, and driving while intoxicated. So what are some of the potential overdose risk factors you notice? So a history of mental health, especially suicidality. Unstable housing, anxiety medication. Yes, using the benzos. Using while alone. Unsecure housing. Yes, using benzos and opioids together, absolutely. Yeah, thanks everyone. So we're seeing that there are some risks here, some risk factors. And so what are some potential risk reduction strategies? What are some things that we could, maybe some information we could provide or some ways that we could help Kelly think about reducing her risk? Advocates can make an OD prevention plan with her, yes. Provide her with case management and wraparound services. She may be interested in counseling. There may be some past traumas and PTSD. Safety plans and stable housing, absolutely. And that all the skills we use in safety planning and helping people increase their safety from victimization, we can use all those same skills in creating a safety plan around someone's use in hopes of preventing overdose, or at least fatal overdose. Housing assistance, absolutely. Thank you, everyone. And so, Ileana, I'll turn it back to you.
All right, thanks, Gabriella. Okay, so these are some of the signs, potential signs of an overdose. So you can see there could be like cold or clammy skin. There could be some discoloration of like fingertips or lips, and that suggests that there's not enough oxygen getting to the brain. There can be signs that the person is demonstrating some shallow breathing, so it might sort of sound like snoring sounds or weird kind of gurgling sounds. The person might have what we call pinned pupils, so the opposite of dilated. They get really, really tiny. But essentially, the key things to focus on are going to be whether the person is having sort of difficulty breathing and whether the person is responsive or not, which I think is on the next slide. Let's see. So there's going to be a little bit of overlap sometimes if somebody is pretty intensely intoxicated. Right, they might be difficult to arouse, they might have sort of slurred speech, and they might have some shallow breathing if the person is just really high. But essentially, if the person is experiencing an overdose, you won't be able to really arouse them, so they're going to be unresponsive to stimuli. And the thing with an overdose is that, you know, in past sort of experiences with overdoses, they have taken, usually takes actually a few hours for the person to actually die, but it really only takes minutes of not getting enough oxygen to the brain for the person to wake up with some permanent damage. And then with fentanyl, of course, because we're talking about much more potent opioids, the overdoses are happening faster. And so there's a much greater need to respond quickly when in the event of an overdose. All right, so these are sort of our key steps that we focus on when training at CRA. So we like to recommend that people start by trying to talk to the person that you believe might be experiencing an overdose. So in the situation of an overdose, you can actually get verbal consent from somebody to intervene or to give them the medication. So I like to suggest that you just talk to the person as you're doing things. So trying to talk to them first, maybe giving them a little shake, but essentially right after, if they're not responsive to those initial cues, you want to go in with what we call the sternal rub, which is taking the knuckles and up and down the chest bone, grinding those knuckles against the chest bone. Any of you listening, if you want to humor me and try that, I like to suggest it because then you know what I'm talking about. It's uncomfortable, but it's a quick way to see if somebody is responsive to some physical stimuli. And then the other option, if somebody, for example, is bundled up with a lot of layers, you could do the same thing with the knuckles just underneath the nose. There's a bone there, and it makes it pretty uncomfortable when you rub it with the knuckles. So that's how we suggest to assess if the person is responsive or not. And essentially, after that, if the person doesn't respond to the sternal rub, then we immediately suggest giving naloxone. And that might sound totally crazy, but the reason we can do that is, one, because so many people are dying of overdoses, right? And the second is because naloxone is really a magical medication that is only for reversing an opioid overdose. So if someone does not have opioids in their system, it would be like injecting them with water, and the person would have no effect on the person. It's incredibly safe. So immediately after the sternal rub, we suggest giving naloxone. There are different formulations of naloxone, which I'll talk a little bit more about later, but the version that we use is the intramuscular version. So we would inject that in a person's muscle, usually the arm. Immediately after, we would call 911. And, you know, we like to suggest either calling 911 or giving naloxone, whichever you can do fastest that you do first. And I like to say that if you have both your phone and your naloxone on you, that you always give naloxone first. And then rescue breathing is often something that you can do as well, that we recommend very highly. And I'll say a little bit more about that later. And then we want to monitor the person until help arrives. So until the paramedics come, you might want to keep doing some rescue breathing. You might need to give another dose of naloxone. So we start with one dose, which is one pre-measured vial. And then we wait a couple of minutes, and after 2 to 3 minutes, if there's still no response, we go ahead and we give another dose. And then lastly would be the rescue position, which I think I'll say a little bit more about later. You can go to the next slide. This is a really nice training video that I recommend folks use unless you have another training video, but it's one that we use pretty widely here in Chicago. So it's a 10-minute video. It's on our website. It's also in Spanish. And here in Chicago and actually in Illinois, all a person needs to do to become an overdose responder is watch this 10-minute video, and they have the basics down. So it can be a great tool for group settings when maybe you're working with participants, or even for staff if you just need a quick refresher. It's a nice resource, so that's available to folks on our website for free. All right, so responding to an overdose should be as easy as 1, 2, 3. So calling 911, giving naloxone, and then doing rescue breathing. When calling 911, we like to suggest that folks focus on physically what you see happening. So if it's an overdose and the person is not breathing, then that's what you tell the dispatcher when you call. In Chicago, in communities among people who are using drugs, people are very hesitant to call 911 for very good reason, because they've often had really terrible experiences with healthcare, because often calling 911 means that the police will show up. And so people are very hesitant to call and typically will just not call at all. And so a lot of our training has focused on really encouraging people that they can still respond in a situation of an overdose and save someone's life, even if they can't call 911. And then trying to problem solve with people so that we can increase their chances of calling 911 while still making sure that they feel safe in the situation. So one example of that is focusing on physically what's happening, calling 911 saying, look, I'm here with somebody, they're not breathing, please come right away. They might give instructions for CPR, and we like to suggest that folks focus just on rescue breathing rather than CPR, because CPR is 30 chest compressions to 2 breaths, and rescue breathing involves breathing more regularly for a person. So anyway, sometimes when you just focus on the physical symptoms and the paramedics show up, sometimes that means the police will not come with them, and it'll just be like, you know, a healthcare emergency response. So sometimes, in our opinion, that's a great way of reducing some harm. But in any case, when the paramedics show up, you definitely want to tell them, hey, I gave this person some naloxone. They're usually incredibly grateful, and that helps them triage if, for example, you know, it wasn't an overdose, and they can sort of quickly move to the next step. So calling 911, giving naloxone, whichever you can do fastest, and then rescue breathing, which is going to be, that involves like making sure the person is lying flat on their back, tilting their head back, opening their mouth, checking the airway to make sure nothing is obstructing, and if so, you want to remove that right away. Then you're going to pinch their nose and start with 2 big breaths, and then we recommend 1 big breath every 5 to 7 seconds, and just keeping that up. So even if for some reason you don't have naloxone on you, breathing for the person until the paramedics arrive can help save their life. So rescue breathing, can't understate just how important that is. All right, next slide. All right, so the recovery position. This is especially important if for any reason you have to leave the person alone. In the event of, you know, you have to run down the street and grab your naloxone kit, or run out to your car to grab your phone to call 911. For any reason you want to, for any reason that you have to leave the person alone, you want to turn them on their side and tilt the weight to one side to make sure that they don't roll over. And this is simply used for preventing if a person, you know, comes to and they're really intoxicated, or sometimes when given naloxone, they could vomit. This is also helpful if folks have had too much alcohol. So keeping them on their side prevents them suffocating on their own vomit if they do vomit. You can also put a person in this position and give them naloxone, but of course, if you're doing rescue breathing, you're going to need to turn them back over and lie them flat on their back. And then I really like to recommend this for people who are actively using drugs, because they often are so scared to call 911, but you can say, listen, you can give your person naloxone, you can put them in the recovery position, and you can call 911, and that gives you time to leave the situation if you're worried about arrest, but leave your person, you know, ready to be cared for when the paramedics arrive, and you can still save their life that way. So some different ways that you can sort of troubleshoot with people to make sure that they're doing everything they can to keep their loved ones alive, but are also able to protect themselves in situations that are really vulnerable. Next slide. All right. All right, so I think I talked a little bit about seeking medical attention already. We do recommend that a person who's overdosed be medically monitored after the experience. But as I said, we know that in community settings, sometimes seeking medical attention may not always be an option for people, especially when people are criminalized for using drugs. So we do recommend the person be monitored, ideally in a hospital or clinic setting, but certainly when folks aren't able or willing to do that, definitely making sure that they're monitored for at least a couple of hours after the experience, you know, by a family member or friend or somebody who can just stay with them is really, really important, because naloxone does wear off. It's very rare. It is possible that in some situations the overdose could come back depending on what a person has taken, various sort of health factors, and when those drugs are like peaking. So it is possible, it's very rare, but what's more likely is that the naloxone does wear off in about a half an hour to about an hour and a half after being administered. And so what is likely is that with somebody who is dependent on opioids, giving them naloxone may put them into withdrawal. And so a person in withdrawal who's dependent is going to be feeling the worst they could possibly be feeling. And if they're dependent, a normative response for them would be to want to immediately relieve that discomfort by using again. So if they're alone, they're at a greater risk of using immediately after and then going back into an overdose, which is why we can't stress enough the importance of making sure that they be monitored. And then one other thing I'll just add is that, the other reason I think it's really important for them to be monitored is that when a person overdoses, that can be a really disorienting and traumatic experience. So having somebody there trained, who knows what to do, who can really help reorient the person after they're sort of like waking up and coming to, because they really have no idea what has just transpired. And if they've overdosed before, they've often had many traumatic experiences associated with that, like not just almost dying, but sometimes people are robbed or they might be assaulted. Terrible things have happened to many people after being overdosed and left behind. So having somebody there compassionate and trained to just explain, this is what happened, this is what you might be feeling, this is what I've given you, I've called 911, and sort of walking them through all of the steps I think is really, really helpful, and also part of providing trauma-informed care. Next slide.
So we wanted to mention that there are Good Samaritan overdose immunity laws in many, many states, nearly every state. And so these laws encourage people to seek medical attention when there's a suspected overdose and offer some protections against legal consequences for use. As you can see, advocacy is still needed in states that have no or little protections for people seeking medical care due to overdose. And some things that we don't want to do during an overdose. And I want to say this with the context that many of the practices on this slide, many people have done in the best intentions of just taking care of people they care about, their friends, their loved ones, their drug-using partners, and that a lot of the reasons why we've done these things in the past is because of lack of information. When we have a research ban on substance use and things like that, it makes it really hard to know what exactly should we do if someone is overdosing. But so here's just some tips on things that we don't want to do while someone's overdosing, and we want to kind of be aware of how these myths might be active and just help provide some clarifying information. So we don't want to put someone in a bath, they could drown. We don't want to put ice on them, they could go into shock. We don't want to try to get them to vomit or give them something to eat or drink because it's very likely they could choke. We don't want to give medications or caffeine or vitamins or anything other than naloxone. We don't want to walk them around. That could waste time, and we could actually kind of trip and fall and hurt one another. We don't want to leave the person to sleep it off if there's any signs of this overdose, and then we certainly don't want to run away, even though it's a very, very natural reaction to have our fight or flight kind of activated during this time.
So in conversations about preventing and responding to an overdose, I think we often don't give enough attention to the aftermath or what happens post-overdose. But I can't overstate how important it is to create space for staff and participants to process the loss experienced after someone we care about dies of a drug overdose. These losses, they're very traumatic, and even responding to an overdose when someone is saved is also often a traumatic experience. Many of our participants have lost countless loved ones to overdose or other drug-related harms. And providing overdose prevention services is providing trauma-informed care because it acknowledges all of this experience, both the needs prior to an overdose as well as the needs post-overdose. It also recognizes that shame and stigma are often the factors most oppressive to people who use drugs. I often have said that losing someone to an overdose is comparable in some ways to losing someone to suicide. while the causes of death are very different, the responses from society are often very similar, that people get very uncomfortable and don't know how to talk about it without so much shame and stigma. And this leaves the folks who are left behind even more devastated by the loss. So these pictures provide a few ideas of how to begin to talk about overdose, remembrance activities for folks lost to overdose, such as the memory wall, things that focus on the person as someone more than just someone who used drugs, right? Remembering the whole person that we lost. And then additionally, on August 31st, every August 31st is International Overdose Awareness Day. So it's a great opportunity to host an event for your participants or surrounding community to talk about overdose and to celebrate the lives of loved ones that have died.
And something I'll offer here too is that as someone who is a director in a program, that, you know, there's always paperwork to fill out whenever there's been a crisis. And so whenever naloxone had to be given or there was a suspected overdose and staff needed to respond to it, if I was present, I would certainly be the lead in supporting staff in that. And even if I wasn't present, any kind of paperwork that needed to get filled out, like a crisis report form and things like that, I would meet with the staff and provide them with emotional support and then offer to do that paperwork for them. Because some staff would feel like it was just like, oh my gosh, I have to think about these, you know, 2 or 3 forms when I'm just kind of trying to work through my own reaction of having just responded to an overdose. And then there are other staff who respond to an overdose and, you know, help revive someone and feel like a superhero and keep on going. And then there are other staff who may be very impacted but find filling out paperwork kind of containing. So just within our role, being able to check in with staff and offer to help in whatever way that they feel would be supportive. So some key steps in preventing overdose. You know, first and foremost is building trusting relationships, a relationship that keeps the door open for discussing substances no matter where someone may be in their own process. And that, if I believe that I'm going to get kicked out of my safe shelter or kicked out of my safety services because of my substance use, that's going to lead to a lot more isolated and potentially risky use. And it certainly is going to get in the way of being able to have open conversation around my reality, around what's going on for me. And it makes it really difficult for us to be able to support folks if there's any kind of threatened kind of consequence with substance use. And so we want to support folks in creating an overdose prevention plan, help them to access naloxone on an ongoing basis, so that folks don't just have to come to us for naloxone, but understanding what are the resources in the community and helping them to access that, helping folks learn that their tolerance changes, and starting low and going slow can be really helpful, especially if there's been any kind of recent change in someone's use or where someone's getting their substance use from. Avoiding mixing substances, especially anything that's considered a downer, using when others are around, and keeping a naloxone kit nearby. And so after we've provided some overdose education and helped folks access naloxone, in order for any of that to be effective in hopefully preventing or responding to an overdose, that information has to be shared with someone else, because overdose cannot be reversed by the person experiencing it. And so something that I like to talk about with folks is, you know, who's around when they're using, who might be around if there were an overdose, who's some safe people that they could share this information with, that they could let them know where their naloxone kit is. And this takes a lot of creativity and brainstorming and coming up with options, especially when people are already experiencing isolation due to domestic violence.
And then just a few things to think about for anyone thinking about starting an overdose education and naloxone distribution program. Things that we have learned are helpful are making sure that the trainings, especially if they're like community focused, that they're short, that they're very like low barrier in terms of accessing them. When distributing naloxone or providing any kind of service, trying to make sure that the data collection is minimal, that you're not bogging people down in paperwork and procedures. Those all create tremendous barriers, and all they do is make people not want to engage in services. Trying to not make it, a medically based program or a high threshold program in any way. So making things much more sort of peer driven, having it be carried out by outreach workers, ideally by people with lived experience, can be really helpful, can help to build trust, and people often respond really well to that when they feel like they can relate to the folks providing the services. Not having rules around the number of refills that people can get, making it unlimited, right? People are often, at least at our program, much of our success depends on something that we call secondary exchange, meaning folks come to our sites and they get supplies for many other people, and they take it back to their networks, because usually there are lots of folks who can't make our outreach times or for whatever reason can't get there. And so folks are helping others by taking extra. So trying to not limit the amount that people can get, I think, is really helpful and makes it much more needs-based. And yeah, then when appropriate, trying to find, new venues and new spaces to train folks, such as, in jail settings or, DUI classes and things like that can be interesting venues to try to have these conversations as well.
So in looking at how we can help people become aware of their different options and how to reduce their risks related to overdose while also supporting their autonomy and their self-determination, this is a method for sharing information that's wholly based in conversation and focuses on building on what the person already knows. This is especially helpful in talking about overdose prevention and really anything related to substance use, because we all tend to shut down when people tell us what we already know. And this is a method that comes out of motivational interviewing. And it's called elicit, provide, elicit. So the first elicit can be as simple as asking permission before we share information, but when it comes to overdose prevention education and supporting folks with overdose prevention, I tend to start with, what are some things you're already doing to prevent overdose? And that gives me an opportunity to really affirm all the steps they're taking to protect their well-being, as well as helps me listen for any things that they might be doing that might be based on misinformation. And then with the provide, in a compassionate, non-stigmatizing, and person-centered way, we can provide information or feedback. And so this is where it can become really helpful to maybe have like a little info sheet on overdose. There are some different ones available on CRA's website, and we have some links at the end that have some different resources that are all free and online. And I always like to ask permission here as well. I have some information on preventing overdose that you might find useful. Is it all right if I share it with you? And then what I consider to be the most important part is the final elicit. And here, we're really asking a question that gets at someone's reaction, helps open the floor to any other questions they may have, as well as helps them think about next steps. So if we're early on in the conversation, I tend to gauge their reaction a little more so, how does that fit in with your experience, or what do you think about that? If we're in kind of the later phase of the conversation, then I usually ask a question of, what do you think you'll do? Or where do you think you'll keep your naloxone kit? Things like that help them really make a plan around the overdose prevention. And so now we'll talk more about naloxone.
All right. So just some naloxone basics. So naloxone is a prescription medication. It only works on opioids, so some of the opioids that Gabriella mentioned earlier. So heroin, morphine, methadone, and buprenorphine are also opioids. Pretty much all of our, many of our prescription painkillers that we're familiar with fall into that classification. But essentially, they are very good at relieving pain and producing a feeling of euphoria. So naloxone only works on those drugs that fall within that category. It has a shelf life of about 2 years, but we also know from research that naloxone after expiration is still effective for many years after. So if all you have is expired naloxone, you will not hurt the person by using it. It's still effective. So it's same idea as, we hold on to like bottles of Tylenol past the expiration date, and we're still likely to use it if that's what we have. The medication just gets weaker, but it's still effective. It has a half-life of 30 to 90 minutes, which I mentioned. Proper storage is recommended at room temperature and out of direct light. So at CRA, we package ours in these little kits in sort of like a dark brown baggie, which helps sort of protect them from light. It's available in a variety of different formulations, but the primary ones that folks are going to have access to are the intranasal, which is right now being marketed under the brand name Narcan, and then the generic, which is naloxone, which is the kind that we give out, and that is in the intramuscular formulation. So it involves a muscle syringe and then a couple of vials. And then we have up top the Evzio, which is sort of the Cadillac version, sort of like the EpiPen, but it's thousands of dollars. So I like to joke that it's the naloxone for the 1% because no one can get access to it. So, but if you can, they're really awesome, and people like them because they have a little, they have like a, what's the word, like a, I'm forgetting what word I'm trying to use, but they have basically a sample one that doesn't have medication that will walk folks through with instructions on how to use it. So they're pretty fancy. So the effective dose depends on the opioid dose as well as sort of other factors, but typically starting with one dose, which is 0.4 milligrams, is the recommended starting dose, and often in our experience is enough for the person to respond. But we do recommend giving people more than one dose of naloxone in case they need more, because there are situations when people need more. So we give people 3 doses of naloxone per kit, and then as many kits as they request. So Narcan can't be abused, and it can't cause overdose. It's incredibly safe. So there have been very, very few people in the world who've ever had any allergy to naloxone, and in our 20 years of doing this, we've never once seen that. So it's incredibly safe, and we recommend the same starting dose for people who are minors, for pregnant women, for older adult men, for everyone. So it's truly a magical drug. There's nothing like it. And the only adverse effects associated with naloxone are opioid withdrawal, and that would really only be for people who are dependent. So naloxone and then is not the same as Suboxone or naltrexone, so sometimes they sound the same, so people confuse them. But Suboxone and naltrexone, as Gabriella referred to earlier, are types of medication-assisted therapies, and naloxone is just the opioid blocker used only for overdose reversals. All right, so in your naloxone kit, we recommend for, if you're a program that's distributing directly to people actively using drugs, we recommend giving people 3 doses. If you just need a couple of kits for your program that staff will use that may not even get used, we recommend 2 doses. So when resources are limited, that's sort of one thing that we recommend for folks starting programs is 2 doses versus 3 doses, depending sort of on your audience. And then making sure folks are trained and maybe have some written instructions on how to recognize and respond to an overdose. And then optional items would be something like a CPR, one-time use CPR mask, and maybe rubber gloves or alcohol pads, although I do have to stress those things are incredibly optional. I can't even, like they're solely optional. And we at CRA never have those optional items. So honestly, things like rubber gloves and alcohol pads, if your program requires it, I suppose you have to do it. But I will say that they add extra time when you need to be able to respond immediately. So just keep that in mind when thinking about putting your program together.
And so something that we found is that naloxone availability decreases fatal overdoses and does not increase rates of use, as Ileana mentioned in the earlier research. People who can prescribe naloxone without any additional waiver, And pharmacists can dispense naloxone without a prescription from another medical professional in every state and in DC. So right now in every single state, naloxone can be gotten without a physician's prescription. Now that said, a lot of the folks we serve may not be able to go to a local pharmacy, may not have access through those ways. And so it becomes really important to also learn what local public health administration and or harm reduction organizations such as Chicago Recovery Alliance may also make naloxone available to the community. And so I wanted to spend a little bit of time talking about overdose prevention for stimulants. So opioids and stimulants, they may be present in stimulants. It's not very common, but it is possible. And that naloxone is only going to be effective for the opioid. And so one thing that folks can do is test their substances using fentanyl testing strips to see if there's fentanyl in their cocaine or their methamphetamine. And that's, fentanyl testing strips are really, really cheap. Ileana, did you want to add anything about fentanyl testing?
Yeah, I'll just say that they're basically the same thing as a urine drug test, but they're largely been used in harm reduction programs like syringe access programs. They have not been FDA approved yet, but there are places that folks can purchase them. They end up being about $1 a strip. But essentially what they do is, you're testing for the presence of fentanyl in a variety of substances. You can test anything from heroin to counterfeit pills to methamphetamine. And it's just about sort of diluting the solution. So depending on the drug, you might need to dilute it a little bit more. The Harm Reduction Coalition has some great resources on their website for folks interested in learning more about them. But we do know from research and from our experience using them in harm reduction programs that they're just another tool for helping people modify risky behaviors when it comes to drug use. So many participants like them and have reported making changes in drug using practices due to having more information about the drugs that they're about to consume, such as, choosing to use less or not using alone or taking other safety measures. So we know that they do have a positive impact when used. So I would encourage folks to read a little more about them on the Harm Reduction Coalition's website, or also we have a couple of resources on our website as well.
Yeah, and here we have the author of a 2018 study that found that people were able to make more informed choices and safer choices around their substance use when they knew that fentanyl was in their substance. And that thinking also for survivors of domestic violence and sexual assault, that many times survivors are being, that the abuser is attempting to control their intimate partner through being the sole source of their substance, and that many times the survivor may not even be aware of what is in their substance, not only because it's coming from it's an illicit substance where really none of us know what's in the substance, but adding the layer of an abuser then kind of keeping that information from the survivor as a way of controlling them. And so we've heard from survivors in the past of them being given drugs that were different than what the abuser said they were, and having really, really negative reactions to those drugs that were provided to them. And that fentanyl testing strips can be a way for them to kind of have more control and knowledge over their substance use. And so we have already talked about how using together can increase overdose risk, and I'm just going to go a little bit faster because we are going to run out of time soon. And so here are some severe signs and health issues related to a stimulant-related overdose. And so what can we do? The unfortunate reality with overdoses from stimulants is that really the only thing we can do is seek emergency medical attention and help kind of support individuals while we wait for emergency medical attention. There's no single antidote for a stimulant-related overdose the way that there is naloxone for an opioid overdose. On the front end, there's a lot of things that we can do around overall health. So health promotion, and Ileana mentioned how HIV and hepatitis C prevention and treatment can be really important to preventing overdose. The same with reproductive health care, safer sex materials, condom negotiation, supporting eating, nutrition, routine health care, and just access to all health care, including behavioral health care. So everything we've talked about so far falls under the umbrella of harm reduction, which has been shown to save lives as well as improve quality of life. Harm reduction is especially important in the context of domestic violence. Survivors have often shared with us many stories of how abusers are forced into use in ways that pose many risks to their health and well-being. And that that substance use coercion goes as far as not allowing survivors to even learn what substances they're using, how to inject themselves, and that all of this becomes a way to further attempt to entrap them in the abuse. And so within anti-domestic violence advocacy, learning about harm reduction and safer substance use practices allows us to then support survivors to increase their safety when it comes to substance use, domestic violence, and substance use coercion. And so here are some alternatives to quitting cold turkey. It's kind of thinking about a whole array of alternatives. And then some information on alcohol, harm reduction related to alcohol. This all comes from a website called kfx.org.uk, where you can find a lot of information on different harm reduction strategies. Here it is for stimulants. And then here's one for heroin. So this gives you an idea of some of the different harms that people face and how we can support them in reducing their risk. And Ileana, could you talk to us about some of the safer use kits?
Yeah, absolutely. So CRA started as an HIV/AIDS prevention organization for people who inject drugs. So our method for doing this was to provide a service that folks both needed and wanted, which was access to new injection equipment and education about how to reduce various risks while injecting. So some of the items you see in the picture are things we distribute to our community on a daily basis, and they include things like tourniquets for tying off and helping people to locate veins. We have a variety of different sizes and lengths of syringes that we offer people depending on, a variety of needs and where they're injecting. In this picture, they show cotton balls. We use actually a different kind of cotton, but it's the same idea that cotton functions as a filter. So people can filter out impurities when drawing up the drug solution that they've prepared, which helps promote better vein care. And we also have the cooker here in the picture, that little sort of metal container. That's what we refer to as a cooker. So that's what people use to basically prepare their drug solution that they're about to inject. So we give people those and things like alcohol pads. We definitely recommend soap and water over alcohol pads, but a lot of times folks don't have access to soap and water. So alcohol pads are the next best thing for helping clean the site that they're about to inject in, and then sterile water to help prep the solution they're about to draw up, which is much better than sometimes what people have access to, which is, sitting puddles of water maybe in a toilet in an abandoned house, or even things like bottled water are not as good as sterile water. And so these are things that we provide folks for safer injection. If you want to go to the next slide. And then some counseling about, better places to inject than others. So all injection carries, a level of risk, but we definitely recommend that folks start, focusing on like the arms and the hands where there's less risk, and then sort of moving to like the legs and the feet. The feet can be risky because, our feet get sweaty and they're exposed to different germs and maybe like the legs and the arms at times, but then really trying to avoid injecting in the neck or veins near the wrist or the groin, as they increase a person's risk of overdose and open people up to all kinds of infections. So definitely people don't start injecting in those places, but we often are meeting with folks who are injecting in those places, and that has a lot to do with just not having blown veins in other places and not having a better place to go. So then it's sort of counseling about how to stay safe, and if, there are times when they can not inject in that place and maybe snort instead. All of these are sort of harm reduction tools to try to minimize a person's risk of death, but also sort of other health consequences as well when injecting. And then this is just a really great resource for folks called Getting Off Right through the Harm Reduction Coalition. It's just a PDF. Anyone can download it. And I really recommend it for anyone who's thinking about starting a syringe access program or is just interested in learning more about safer injection practices. And then similarly, we have some resources on our website as well, and they're in a couple of different languages, although those translations may be a little bit old, so it may not, I don't know if I can speak to the quality of some of the translations, but they're there. And certainly if folks have questions, please reach out to us. Recently, in 2018, we launched a couple of new initiatives to expand our overdose prevention services. And the idea was that we wanted to reach people who otherwise had no reason to come to CRA because they weren't injecting drugs, right? So we decided we wanted to have a way of engaging people who were snorting and smoking drugs who were also at risk of overdose. So we started to put together some safer use supplies for people who snort and for people who smoke, and they were based off some other programs who'd already been doing this work. And so this is a pretty comprehensive kit. We don't include all of these materials in our kits anymore, but they're still available to people. So we have different colored straws. The reason is so that people won't share the same straw. We have a little scoop so people can, scoop out the amount that they want to snort, plastic razor blade so they can crush the drugs, and a credit card so they can separate the lines. It could also function as a cleaner surface to snort off of. And we have some vitamin A and D ointment because a lot of people develop sores in the nose if they're frequently snorting. And sometimes that has more to do with the cut of the drug than the drug that they're seeking out intentionally. And then some sterile water for rinsing and things like that. So we use that as our safer snorting kit.
And Eliana, why is it important that people not share straws?
Oh, I'm sorry, I forgot to mention that. Well, so there's a lower risk with transmitting hepatitis C through straw sharing, but really the idea with hepatitis C, which is actually much more frightening than HIV, is that hepatitis C can live outside of the body on surfaces, right? And it's transmitted through blood. So anything where there's any sort of portal of entry, right? So anyone who, isn't living in the best of conditions and is struggling with chaotic substance use may have a variety of ways of getting, contracting HCV and possibly transmitting that to someone else. So sharing straws with somebody when somebody has a bunch of open sores in the nose, or similarly with rock cocaine with somebody who's smoking frequently and has a bunch of sores on the mouth, and sharing that with someone else. So it's one of our ways of both preventing hepatitis C transmission, talking to people about safer drug use, and also getting them to start thinking about overdose prevention, because many folks who've been snorting and smoking have not had to think about naloxone before because smoking and snorting has largely been protective, but now the game has changed. So lots of ways to really engage people around their drug use that have proven to be very helpful. So then we have our safer smoking kit. We have a glass pipe that's pretty thick, so even if you drop it, it usually lasts a little while. We have a spark plug cover, which we actually use as the mouthpiece to put over the pipe to help protect people's lips. So we use that as a way to talk to people about, preventing burns, not sharing a pipe, but certainly if they only have one pipe and they have to share, then one way they can protect themselves is by making sure that they have their own mouthpiece. We have a chopstick that's cut in half that's used for a pusher that's to manipulate the contents of the pipe. We have a little paper clip, which is really optional, but a lot of folks like it to scrape the residue that sort of builds up on the inside of the pipe. When people are running low on money, they sometimes will scrape the residue and just smoke what they have left in there. We have a little bit of copper mesh wire in there, which is known as Chore Boy. So that's the name brand of the copper scouring pad. that is sort of like a filter. It really doesn't have any health benefits. In fact, it's pretty bad for you. But the reason we provide it is because it's a key element of the smoking kit. People can't smoke the crack or the rock cocaine without this piece. And it's important to get the brand version of this material versus off-brand copper, mesh copper scouring pad, because off brands, you're unable to burn off the copper coating, and the copper coating is very toxic. So we provide the name brand for that reason. And the other reason is that when people don't have access to chore and it's very expensive to buy, people will just reuse it, which tends to break down, and that's what causes openings in the mouth and gets lodged in people's lungs and causes all kinds of terrible health consequences. So talking to people about, replacing these items is a good way of talking about health promotion when people are experiencing chaotic drug use. And then we have a couple other sort of self-care items like lip balm. This one's really nice because it's not petroleum-based, which means it's not at risk of tearing condoms if people are engaging in sex while using. And then we have our vitamin C, which is really good for folks just regularly using cocaine, as cocaine depletes a person's natural vitamin C. So we can talk to people about, keeping their immune system in good shape. But it also can help people break down the rock if they choose to inject the crack cocaine. So anyway, just that's a little bit about our safer smoking kit.
And so in the last few minutes, we're probably going to run out of time before we get to any questions. So our contact information is on the final slides. I want to welcome everyone to reach out to us with questions. And then we're going to spend the last few minutes talking about really kind of what's next, what's cutting edge, what's the innovation in overdose prevention.
All right, so CRA, in February this year, we launched a new pilot program called the Alliance for Collaborative Drug Checking Real Time, or ACDC, which is kind of fun to say. But this project was something our founder, Dan Bigg, had been working on for the last few years before his death, so it's been exciting to actualize one of his final projects. Basically, building off of the fentanyl test strips, it's basically, the same idea. The more information participants can have about their drugs pre-consumption, the more informed their drug using experiences will be, similar to the idea, right, of like informed consent. So up to this point, the only real information we've been able to get about substances has been from the medical examiner's office once a person has passed away, or from law enforcement post-drug seizures, but nothing has existed for people actively using to make more informed decisions. So this has been really exciting. So our process involves triangulation. We test each sample with an infrared and a high-pressure mass spectrometer, and then compare those results to a fentanyl test strip. So we use 3 different methodologies for testing a person's sample. So the program functions on a volunteer basis, only where participants will bring in a sample either pre or post-consumption to test trace amounts of their substances. So we can look at an empty baggie, for example, but it's very, very small amounts. So we're not just collecting a bunch of drugs. We actually, as a syringe access program, have a ton of access to a bunch of paraphernalia already, because we collect used equipment and dispose of it safely for people. So in some ways, this isn't something very new, but now we can actually test it, which is new. So our hope is to be able to help detect the presence of fentanyl in people's drugs, but we don't exclusively focus on opioids, so people can really test anything, but it's a way to give people more information about what they do so that they can then adapt their using practices to increase their safety and reduce their overdose risk. And then we have our community overdose prevention program, which was a pilot that we launched in 2018. And this is the program I had the privilege of getting to run. This was intended to be a community health worker model for people who use drugs, focused on expanding CRA's overdose prevention work. So the purpose was to reach the unreached. In other words, people affected by overdose who are not already connected to our services. So the city of Chicago had compiled an EPI report on overdose deaths, and we learned at that time just how great the disparities were in our city as it related to overdose fatalities. So we learned that 2/3 of the deaths in our city were among people of color, and 1/2 among Black or African American persons. So this was a huge disparity because we knew that people of color were not using more drugs than their white counterparts, but yet we're dying at much higher rates. And what was that a result of? Well, that was clearly a result of access, right? So despite having outreach sites existing in all of the community areas hardest hit by the overdose crisis in Chicago, there were still many people who were not receiving the naloxone and the education. So we determined that many of these people who were not connected to our services were people who were likely snorting their drugs rather than injecting. So snorting was once protective, as I'd mentioned earlier, but is no longer due to fentanyl. So we decided, in part, that was what the smoking and snorting kits were also part of this initiative. But we decided to draw on this knowledge to form a peer-based program focused on street outreach. You can go to the next slide, Gabriella. Oh, actually, we jumped that. That's all right. We stay there. So we recruited people who were actively using drugs and trained them to become overdose educators, who we then called community health educators. And they were compensated for their time to go out and train other people on the street who were actively using, or people who knew people who were actively using, like family members and friends. And they distributed a ton of naloxone. And essentially, we had some pretty incredible numbers. We had funding for 9 months, and within that time, our health educators reached 3,445 new people through these efforts, which resulted in the distribution of 8,727 naloxone kits into the communities hardest hit by the crisis. So that was really, really exciting. And I think we had a lot of successes and opportunities. There's a little bit of this information also on our website, so I won't spend too much time. But I think the main thing is that anytime you involve people with lived experience who are still actively using, it's not only like a rewarding experience, but it's actually a very effective way of trying to reach other networks of people actively using, and it works. So hopefully maybe some of you will think about trying a similar program.
Thanks so much, Ileana. So we are over time, so I want to just very, very quickly share what can we do next steps. So first off, now that you have this information, sharing this information with survivors, colleagues, friends, family, and neighbors. We are in the midst of an overdose crisis, and so sharing this information and advocating for access to naloxone, the overdose antidote. So supporting naloxone access by having it on site, as well as helping survivors to access take-home naloxone kits, supporting legal protections for people seeking medical care for suspected overdose, fighting stigma within ourselves, our programs, and our communities. And you can also plan an event for International Overdose Awareness Day, which is August 31st. Now, these events help raise awareness as well as help honor those whom we've lost to overdose. And here is a website that has a whole bunch of toolkits and free resources and ideas for how to plan your own event. And here's some information and resources. Going to move forward through these. And then here's Ileana's contact information, our contact information, and we most of all want to say thank you.
Well, I'm going to thank you as well. Thank you, Ileana and Gabriella, for today's webinar, and thank you to Carla for making the webinar run so smoothly. Last but not least, thank you all for spending your time with us at the National Center on Domestic Violence, Trauma, and Mental Health. Within the next week, we'll send you a follow-up email with a link to the recording of today's webinar, in addition to the slides and handouts referenced, all of which will be available on our website. You'll also receive a certificate of attendance for your time today. Again, in a moment, you'll be taken to a very brief evaluation. If you could please take a moment to let us know what was useful and what could have been better, we'd be very appreciative. And also any suggestions for future webinars to build on this or on other topics. And also, since we didn't have time for the Q&A, please feel free to contact Gabriella and Ileana with questions that you may have about the webinar. And we will be having another webinar. Gabriella, the date is November...
It's the Monday, I think it's November 19th. Oh, I'm so sorry. I should have had it right in front of me.
Well, we'll send that information out as well with the information about today's webinar. Anyway, thank you
November
again,
18th.
and we hope November 18th. Yes, but that'll be on the substance use the guide that Gabriela has been working on for DV programs on working with survivors who use substances. We'll have a whole webinar series on that. So thank you again, and we hope you all have a wonderful afternoon.